So the title of my presentation today is Dropping the MIC, and it's a review of updated breakpoints and implications on clinical practice. Me nor my preceptors have any disclosures to present on. And for learning objectives, we're going to be interpreting antibacterial culture and susceptibility report utilizing a patient case, evaluating new literature and rationale for changes to antimicrobial breakpoints, and designing a patient-centered treatment regimen based on updated breakpoints. And the data and information discussed will be limited to antibacterials and their breakpoints, not antifungals. So I wanted to take a minute to talk about AST significance. So a patient presents to hospital and is found to have a bloodstream infection. Blood cultures are collected and sent to microlab where organism is identified and AST is performed. The patient is started on medication based on AST, but is not improving, and the patient transfers to another hospital. Blood cultures are collected again, and patient is now resistant to the original medication. Another medicine is started based on new AST, and patient improves. It's the same organism identified. However, some possible explanations are the organism became resistant or the labs between the two hospitals use different breakpoints, which is used to classify the probability of treatment success. So the significance of AST really does impact patient outcomes. Some AST limitations, so it's based on in vitro antimicrobial activity, not based on in vivo factors or how the drug really works inside our bodies. Therefore, in vitro susceptibility does not equal in vivo efficacy or treatment success. It doesn't consider patient-specific factors such as allergies, clinical condition, renal or liver function, or immune status. It doesn't take into account organism factors such as toxin production or even presence of biofilms. And PK/PD of antimicrobial is an important consideration as we use PK/PD to optimize our dosing regimen to ensure appropriate concentration at the site of action. And lastly, it doesn't take into account costs and availability of the drug. So those are things that also need to be considered. So our interpretation of susceptibility results, so we all know susceptible means high chance of treatment success and resistant means low chance of treatment success. But some other categories, so susceptible dose dependent. Susceptibility depends on the dosing regimen, so you can either have higher doses, more frequent dosing, or plus minus extended infusion time. And then intermediate category was really made to address testing challenges, and it's generally regarded as resistant. It's the buffer zone of variability or uncertainty for AST tests, which should prevent major discrepancies in interpretations. So some basics for cultures and susceptibility. So MIC range is different for each and every antimicrobial tested. MIC values are not directly comparable. Picking the antibiotic with the lowest MIC is not the best choice. And so the definition of breakpoint is highest concentration of the drug that can safely be achieved to determine susceptibility. So in general, the isolate is most susceptible to the antibiotic furthest from the breakpoint. So in this example, you would see cefepime would be the best choice because it's 2 dilutions away from the breakpoint. So this brings us to our first question. What is the highest plasma concentration of the drug that can safely be achieved in a patient to determine susceptibility to an organism? You guys can yell it out or put it in the chat. That's fine.
You already put it in the chat.
Excuse me.
Anybody have any
Well, what did you say?
That was MIC.
Some people here are saying MIC, someone's saying breakpoint. That's a split.
So it's breakpoint. MIC is the lowest concentration in antimicrobial, inhibits visible growth of a microorganism. And then question number 2, so if obtaining I or intermediate in a culture and susceptibility report, one can generally assume, so either higher dose or more frequent dosing is needed to achieve MIC target. The isolate can be regarded as resistant or area of technical uncertainty.
People here are saying D.
Yes, that's correct. Alrighty. So now moving beyond the susceptibility report into inducible resistance or AmpC. So AmpC beta lactamases mediate resistance in penicillins, early generation cephalosporins, and beta lactamase inhibitor. Bacteria at first appear susceptible to an antibiotic, but after exposure to, for instance, ceftriaxone, this leads to treatment failure. So third generation cephalosporins induce AmpC production and are not effective if suspected AmpC. Resistance can develop in 3 to 4 days and after just a couple doses. And there's no tests to really determine if AmpC is occurring, but in this picture to the right, this is typically the phenotypic presentation where you see resistance to first generation cephalosporins and then still showing susceptibility to third generation cephalosporins. It's typically treated with cefepime or non-AmpC producing antibiotics, such as fluoroquinolones, Bactrim as appropriate. So the space and spice organisms historically were known as AmpC producers. However, they were associated with undercalling and overcalling of clinically significant AmpC. So per the new IDSA guidance document on antimicrobial resistance, gram-negative infection, these are the organisms for clinically significant AmpC. So you can refer to this mnemonic heck yes, and the moderate to high risk producers are in this red box, where inducible AmpC resistance may occur in approximately 20% of infections caused by these organisms after exposure to ceftriaxone. And then for ESBL enterobacterialis, this has increased significantly. The occurrence of these organisms has increased significantly in the US by 53% from 2012 to 2017. ESBLs inactivate most penicillins, cephalosporins, and aztreonam. They're generally susceptible to carbapenems. Another caveat is ESBLs do not inactivate non-beta lactams, so fluoroquinolones, nitrofurantoin, Bactrim, and gentamicin. Any gram-negative can harbor ESBL genes, but is most prevalent in E. coli, Kleb pneumo, Kleb oxytoca, and Proteus mirabilis. Routine ESBL testing is not performed by most clinical microlabs. Non-susceptibility to ceftriaxone is an MIC of over or equal to 2 is often used as the proxy for ESBL production. And this now shows in our BCID panel as well. And previous to that, we do have like a spot in the lab where it shows when ESBLs are present too. So which of the following is one of the most prevalent organisms for AmpC production? I'll give you guys about a minute.
B. People here are saying B.
Yes, that's correct. So I just wanted to list this one because for ESBL, it's different type of Kleb. So that brings us to our next question. Which of the following is one of the most prevalent organisms for ESBL enterobacterialis production?
C. People here are saying C.
Yes, that's correct.
Good job.
I'm the spokesperson.
Thank you.
Yeah.
So our next question, Mr. XY is a 60-year-old male with recurrent UTIs. Urine cultures resulted. Patient on a course of ceftonir without relief. Cultures now intermediate to ceftriaxone. What is the likely phenotypic presentation of this patient? I'll give you guys about a minute.
ESBL susceptible.
ESBL, even though it says negative on
What's the result?
ESBL negative,
ceftriaxone.
ceftriaxone I. What else do you want to know? Docin I, levofloxacin R, Cipro R,
It's equal.
cefepime S.
So it's ESBL, you guys are saying? Yeah.
Yes.
Yes.
That's correct. So this fits most likely ESBL picture, even though the lab is reporting as negative. So if you notice the ceftriaxone MICS2, which we know is a proxy for ESBL, occurring. Plus, we know that E. coli is one of the most common ESBL producers versus AmpC producer. So if this was an AmpC producer, would likely read susceptible when it's not, versus here it's resistant. And lastly, we know that it doesn't show susceptibility to carbapenem, so that's not the correct choice. So A is the correct choice. So now going into breakpoints, introduction and who determines breakpoints. So these are the standard development organizations. These are the most prominent organizations that set breakpoints for different organisms and antimicrobials. FDA is a regulatory organization which recognizes standards for AST. FDA is also very important because the AST device manufacturers and laboratories must use FDA recognized breakpoints. CLSI and UCAS are two other standards development organizations. CLSI works on a global scale, and UCAS is the European Committee on AST testing, and they work independent of the FDA. Lastly, USCAS is the US branch for UCAS, and they focus on older antimicrobials where there's a big need to modernize breakpoints. So I just want to highlight that breakpoint information may or may not match within these different organizations. And then for the US, it's especially important when the FDA has different breakpoints than CLSI. This has really big implications on AST devices and laboratories. So I'll kind of touch on that in the next coming slides. So these are some terms throughout the presentation and in the resources. The M100 is the CLSI standard that lists all the CLSI breakpoints and quality control ranges. And then micro labs cross-reference susceptibility if using CLSI standards, which we do here. And then just to highlight again, that AST device manufacturers and laboratories must use FDA recognized breakpoints. So how are breakpoints established? There are certain triggers to breakpoint establishment or revision. So it could be recognition of new resistance mechanisms, new PK/PD data, dosage changes, formulation changes, or differing breakpoints between the different organizations. So these signals arise, and then an investigation is performed by the standard organizations to determine if a breakpoint revision is in order, and they look at in vitro data, PK/PD data, and prospective clinical studies. And it's important to balance all these areas out because what may look very good in vitro data may not look as good in clinical studies. So this is an overview of how breakpoints are updated. It's complex and takes a long time. It can take anywhere between 1 to 10 years. It affects laboratories and AST devices tremendously. This is why sometimes labs still report things as susceptible, even though the breakpoints have changed, because they could be waiting for FDA to update their breakpoints or AST devices to adopt them. So it creates a lot of confusion between healthcare providers. So if a breakpoint is different than FDA breakpoints, it may be because the FDA hasn't recognized or accepted CLSI breakpoint. Laboratories can perform internal validation studies to use the CLSI breakpoints off-label. So that's really important. So this is a very complex process, but you can refer to this slide for more information. And then I also listed the rationale documents that CLSI submits to FDA for review so that the FDA can adopt the CLSI breakpoints. So for question number 6, why is it so important that breakpoints are recognized by the FDA?
People are saying D here.
Yep, that's right. And now moving on to the actual clinical breakpoint updates for pip/tazo and aminoglycosides. So this is a timeline of the pip/tazo breakpoint updates. So in 1992, the breakpoints were established for Pseudomonas and for Enterobacterales. In 2012, the Pseudomonas breakpoints were updated. In 2022, the Enterobacterales breakpoints were updated. And then recently in 2023, the Pseudomonas breakpoints were updated. So I'm going to start off first by talking about the Enterobacterales updates. So what led to the newest breakpoint revisions? So pip/tazo actually had information in all of these areas. So there was new surveillance in vitro data, new PK/PD data, and then clinical outcomes data. I'm going to focus today on the clinical outcomes data, focusing on the Merino trial and then the post-hoc Merino trial. So the Merino trial, what sparked this trial was published in 2018, and it has been known that carbapenems are the gold standard for ESBLs, but more prevalent use also increases antimicrobial resistance. And then there was also observational data that suggested the combo of beta-lactam and beta-lactamase inhibitor antibiotic may be clinically effective for treating infections caused by ESBL bacteria. So that's what kind of sparked this trial. So the clinical question in patients with ESBL-E. coli or Klebsiella is pip/tazo non-inferior to meropenem. The study design was an international multi-center study, open label, parallel group, non-inferiority, randomized controlled trial in 26 hospitals and 9 countries. And the population had comparably matched arm to pip/tazo and meropenem. So for the trial, the intervention was hospitalized patients with at least one positive blood culture to either E. coli or Klebsiella. The dosing is listed there for the different drugs, minimum of 4 days to maximum of 14 days. On day 5, the primary treating team had the option to cease all antibiotics, continue the allocated agent, or change to step-down therapy. And then the non-inferiority margin was 5%. They looked at, for the outcomes, primary outcome was all-cause mortality at 30 days, and secondary outcomes are listed there for your reference. So for primary outcomes, you can see the big difference between pip/tazo and meropenem 30-day mortality. And the study was actually terminated early after finding significantly higher mortality by day 30 for patients receiving pip/tazo compared with meropenem. The median pip/tazo MIC was 2. There was no significant difference in the median MICs of pip/tazo between the treatment groups, and there was also no clear relationship between pip/tazo MIC and mortality. So this sparked the post hoc Merino trial. The authors wanted to see what exactly happened since all the patients included in the Merino study, the isolates were supposed to test susceptible to be included in the study. And this post hoc study was published in 2021. So they found that when they redid reference broth dilution, the susceptibilities were different. And then of all the isolates that tested susceptible to piptazo, 17% had MIC values within the area of technical uncertainty category. There was significant 30-day mortality difference for patients treated with piptazo at a breakpoint of over 16 compared to less than 16. So this is what kind of sparked the breakpoint revision. So these are the new breakpoints and dosing recommendations. So you see here how the breakpoints were significantly lowered from 1992 to 2022. And then these are the different dosing strategies depending on the MIC. Where you see MIC of less than or equal to 8, you can do standard or extended infusion dosing, and then the dose depending on the indication. It's still preferred to do extended infusion dosing per our SOP, which shows better attainment of PK/PD targets and cost savings. But for MIC of 16, this is a susceptible dose dependent recommendation, and your only option is high dose extended infusion, and really should consider an alternative. And we've provided education to pharmacy teams and otherwise to consider alternative agent or ID ASP consult. So it's just really important because the higher doses can increase your risk of toxicity. So really, if there's another agent, we should be looking, to use something else. And then for now, in a presumed or confirmed ESBL, with a confirmed ESBL or presumed ESBL, there's no CLSI recommendation to hide susceptible piptazo results or change interpretation to resistant. So use caution with that. And it's especially important with non-urinary cultures. And this may be something that ASP works specifically with laboratory in the future. And I have an example of that in the next coming slides. So for questions 7 through 8, Mr. ZZ is an 81-year-old male presented with altered mental status, signs and symptoms of pyelonephritis times 3 days, no drug allergies noted, blood and urine cultures were drawn, and patient was empirically started on piptazo. The blood cultures come back and it's ESBL-E. coli. Based on the knowledge reviewed and information from the Merino trial, how do you tailor therapy? Do you continue piptazo? Do you switch to cefepime? Do you switch to ertapenem or none of the above?
C. People here are saying C.
That's correct. So yeah, it's the gold standard for treatment, especially for bacteremia. And cefepime obviously is not an appropriate choice because would be hydrolyzed by the ESBLs similarly to piptazo. So let's say this was not an ESBL-E. coli and the MIC is 16 and there were no alternative options. What would be the best dose and dosing strategy for piptazo? Best choice.
C. Don't give it. People here are saying C.
Yep, that's correct.
Higher dose extended infusion.
Mm-hmm. So this is also supported by our SOP, where we can, the pharmacist can also change the order as well. And then just to note that these recommendations are for patients with normal renal function. So obviously if there's altered renal function or dysfunction, then we would have to dose adjust. So now moving on to the Pseudomonas breakpoints. So for Pseudomonas, the clinical data was limited to observational studies, but you see where MIC of less than or equal to 16 there was more favorable outcomes and or reduced mortality. So that's kind of where those breakpoints originated from. So you see here throughout the different years how it's continued to be lowered. And then for 2023, resistant was significantly lowered, and then intermediate is now just 32. So for here, for MIC of less than 16, you have the 2 dosings listed per indication, but both are extended infusion. If the MIC is 16, it's more frequent, higher dosing extended infusion to really hit those PK/PD targets. This is the dose per CLSI, but at this point, we really should consider an alternative or IDASP consult, which is what we've instructed, the teams and stuff to do. And then this is also dosing based on normal renal function. So we've actually updated our guidebook as well to include the new breakpoint information. So if you notice on the bottom right, it'll say for Pseudomonas or Enterobacterialis, MIC of over or equal to 16, consider alternative agent or contact IDASP. So I believe the book should be getting printed in April as well with this information. All right, so now moving to aminoglycosides. So the breakpoints for aminoglycosides have not been re-examined since the 1980s. In 2014, the US CAS began the process to evaluate aminoglycoside breakpoints in vitro susceptibility, and results of these analyses were shared publicly in September 2018, and an updated report was issued in February 2019. So they looked at modern PK/PD, dosing modalities, in vitro surveillance data, and combination therapy and infection site. So these are the changes and considerations for Enterobacterialis and Pseudomonas aeruginosa. So there's elimination of GENT as treatment option for Pseudomonas. So the isolates they found were not treatable with GENT. There was increasing GENT dose is not possible. So GENT is completely eliminated as a treatment option for Pseudomonas. And then the CLSI M100 addition was established using a stasis endpoint. So that means either stopping growth or growth remains stable endpoint rather than a cytal or bacterial killing endpoint. So aminoglycosides may be preferred for these organisms in instances where there's lower bacterial burden, good source control, fewer comorbidities, or the consequences of inadequate therapy are low. Then for monotherapy, it's only for urinary tract infections. Aminoglycosides should not be used as monotherapy for systemic infections. And then in this case, if monotherapy, is truly desired, consider ID consult as well. And then for amikacin and Pseudomonas, it's only now for urine infections. So these are kind of a general overview of the big changes that happened in the breakpoints. And this is also like a visual as well. So for GENT, it was completely eliminated as a treatment option for Pseudomonas. And then lowered, the breakpoint was also lowered for Enterobacterialis across the board. For tobramycin, the MIC was lowered for Pseudomonas. And then for amikacin, it was changed to urine only for Pseudomonas. So this is also the aminoglycoside breakpoints with their dosing as well that correlates. So just to highlight again, GENT can no longer be used for Pseudomonas, amikacin is only for urine, and then all other breakpoints have been lowered, and then the dosing recommendations listed as well. So I want to highlight for CLSI dosing recommendations for aminoglycosides. So this is this is a little bit also more pharmacist led, but just to kind of talk about the dosing. So there's extended interval dosing and conventional dosing. So for Enterobacterialis, we have for Gent and Tobra, it's 7 mg per kg, and then for amikacin, it's 15 mg per kg. And then for Pseudomonas, like I mentioned, has no interpretation. Tobra is 7 mg per kg, and then for amikacin, it's 50 mg per kg only for urine. So this is the dosing we will see most often for single dosing, but may be contingent on patient-specific factors and may be provider-specific. So if a patient is elderly and want to do slightly lower dose, those are possible options as well. And then there was no changes to conventional or HD dosing for aminoglycosides as of yet, but this is an evolving area, more information to come. So we typically use extended interval dosing versus conventional dosing. And this is the information in our guidebook as well, where there's slight updates that are needed. So this is something that we've updated for Gent and Tobra would follow the 7 mg per kg for Hartford Hospital nomogram. And then for amikacin dosing would still follow the Barnes Jewish nomogram. That's kind of a little bit more pharmacist centered, but I just wanted to mention. And then for conventional HD dosing, there's no changes as mentioned.
Sanchez, before you go
Yes.
forward, this is Anthony. So I want to ask the group a question. So based on what Sanchez has just told you, all right,
Sanchez.
and so
Oh.
her maiden name is Sanchez, so I call her Sanchez.
Mm-hmm.
So why do you think that the breakpoints for aminoglycosides have gone to hell in the handbasket in such a short period of time? Hypothesize.
So what else?
Has some plasmid-mediated resistance cells.
Okay. From what?
Other, yeah,
Like what?
fungi. Pseudomonas.
No, like give me another drug.
Cipro.
Fluoroquinolones.
Yeah.
So the main thing is that because, when they started doing a deluge of fluoroquinolones back in the 80s, right, John? When they started to flood the market with these things literally, and everybody was using them for everything, it probably started to, change the aminoglycoside resistance patterns specifically in gram negatives, right? And so because they're on the same plasmid, I taught all of this. You haven't come through ASP yet, so you're forgiven. Everybody else in this room has gone through it, so they get it. But, that's probably the biggest thing. John mentions that it's not use. The question is, has prophylaxis in ORs, then could that be, it's a hypothesis. It's not a causality. Is that also part of it, since now it's not used as much as prophy by the urologists as it was 15 years ago? Could that have started this, and then the use of fluoroquinolones took us over Niagara Falls here?
This has happened before, like in the late 70s, the 1970s, going through the 80s, where it was overuse and it developed resistance. So when they backed off of using it, then you saw everything going back to susceptible because it was pressure. What have you talked about, stable derepression and all that kind of stuff? So when these things got susceptible, or you're exposed to antibiotics, if there's resistance genes, so it becomes derepressed, and then you start seeing it. But if you're not using it, it goes back to be hidden, so it doesn't show up in susceptibility testing. So that one people kind of figured out this is different.
Kurt, what's your question?
By that definition, patients at Moffitt would fit that category because we use Cipro levofloxacin like water over there.
Exactly.
Among
Among other things.
But I mean, every patient's on Cipro or levofloxacin.
Right, and that's why this is such doom, because again, you have to do something. I understand that. Okay, I trained with BMT for years as well. I get it. You have to do something. At the same time, The question is, for how long should these people be on that? Because, you know, if you do not have aminoglycosides in your armamentarium, you're in deep crap, right? And especially, you know, I understand what Sanchez was saying about, well, you could give a lower dose. If you're giving a one-time dose of aminoglycoside, you not give a lower dose. You give the full Monty, right? It's like you're going to go to McDonald's and have a crappy meal. Fine, you get the whole thing. Right? You don't get a Diet Coke.
No.
You get the whole damn thing, and you do that, right? Does that make sense?
Yeah.
So that's the reason why you have to understand. Right, exactly. Get the Big Mac with the extra sauce. You know?
Supersize it.
Exactly, or like Rybalt going down a volcano. It's this kind of thing where, you know, you've got to understand some of the history of it and what could be why the resistance pattern is the way it is and how to avoid problems with it, especially somebody who's septic as shit. Continue.
I just was going to say it too. It seems like, so if you're at Moffitt then, and you've got a gram-negative rod bacteremia, someone's in septic shock, we probably should be doing tobacam preferentially.
Yeah.
If you're not supposed to give for Pseudomonas only in the urine,
Right.
and you don't know what it is, right? You should probably just be reaching like straight into Cobra.
Precisely, and that's a big deal, especially now, again, if you're trying to clear cystitis or early pyelo, if you're suspecting it, which is hard to do in those patients because they have like 2 neutrophils running around terrified, fine, right? And they have no antibody, they have no IgA, okay? They do not have an immune system. So the alarm system is not going to be on point as it would in somebody here at the VASPA, okay?
Right.
Now, again, but you're right, Chobra should be the drug to be used based on this data.
Yeah.
Period.
Empirically, yeah.
And even if they're on hemodialysis, we're still going full court.
Yeah.
Okay.
Again, think of the McDonald's reference.
You going down the
You're going to go down, you're going to supersize it. You're not going to sit there and get a Diet Coke and a salad at McDonald's. Understand?
Well, these patients are dying, right? So like when you're giving a patient a dose of an aminoglycoside, they're dying.
like you in the volcano.
Or I'll get off my soapbox. Right, Sanchez.
All right, thank
You can proceed.
All right, so then the implementation of the breakpoints. So the new breakpoints are found on the notes page of the inpatient, outpatient, and microbial guidebook. Gentamicin will be suppressed on all cultures growing Pseudomonas aeruginosa. Amikacin will be suppressed on non-urine cultures growing Pseudomonas aeruginosa. And tobramycin, just want to mention tobramycin susceptibility, or tobramycin does not predict susceptibility to gentamicin. So that's really important. And I know that you guys were saying kind of using tobramycin empirically, which makes sense based off of, you know, this information, kind of like a good rule of thumb. Please review M100 to ensure susceptibility of aminoglycosides or reach out to ASP for review. And then combination therapy for most indications other than UTI should be considered. So for questions 9 through 10, patient case. So Mr. Z is a 72-year-old male with AML, status post-induction chemo, developed a fever 2 days ago, empirically started on meropenem. Blood cultures are 4 out of 4 for Pseudomonas aeruginosa and no reported drug allergies. So without knowing the interpretation, just based on the case and application of new breakpoints, which medication is not an appropriate option for this patient?
None of these
People are saying
medications are appropriate.
Oh.
Yeah. Why would you give any of those right now?
So both A and B, yep. So amikacin, like mentioned, is only for urine, so it's inappropriate. And Gens is not active at all for Pseudomonas. So not even knowing, you know, your MIC interpretations, you can eliminate those options. And then for question 10, what would be the most appropriate therapeutic option to switch to? So patient was empirically started on meropenem. Would you switch to amikacin, ertapenem, ceftolozane-tazobactam, or continue with meropenem?
C.
Yeah, see.
That's correct. So we know that ertapenem doesn't cover Pseudomonas. Amikacin has no interpretation for bacteremia, only in urine, and meropenem is resistant, so this is the only option. So I just want to mention as well that the new M100 just came out, the 34th edition. And the website actually changed quite a bit. If you're used to like the older website. So this is a screenshot of what it looks like now. Significant reorganizations of dosing recommendations for this edition, the addition of sulbactam, durlobactam to the breakpoints. There's also a new table for Salmonella and Shigella. And then this link is to an update webinar that's going to be happening April 17th from 1 to 2:30 p.m. if anyone's interested. I did reach out to Micro to see if they are able to get that webinar like registration for free. And I don't think that they are. So if anyone has like information about it, I would like to attend. I just was wanting to know if there was like a free option, but I don't know if anyone has heard any information about that, or probably Micro might loop us in to any changes as well, but just wanted to mention.
Cool.
And then,
No, nothing, sorry.
oh no, it's fine. And then, so for some resources, so this is our MIC and CLSI breakpoints, which again are listed in the guidebook. And then I have some extensions, which you all probably know. And then CLSI free resources, links, the CLSI AST rationale documents that they submit to the FDA for approval of their breakpoints. Or for the FDA to adopt their breakpoints, in other words, and then the CLSI breakpoints links, and then the CLSI website is a bit kind of confusing to navigate, so I did like a video of a screen share of how to go into the website and find all the resources. So if you guys want to click on that link, it's this last link here. So to summarize, refer to the M100, CLSI, Enterobacterialis, and Pseudomonas aeruginosa breakpoints for indication and dosing specifications. Consider ID ASP consult for pip/tazo MICs of over or equal to 16 for Enterobacterialis and Pseudomonas aeruginosa. We've provided education about that to like our pharmacy staff and everything. So the team pharmacists are well aware of that breakpoint cutoff. And then for Pseudomonas aeruginosa, gentamicin no longer has an interpretation, and amikacin is only for urinary sources. And then if need further interpretation for culture and susceptibility report, obviously reach out to you guys. So these are my references. And I want to thank Sid and Sung-Soo for their help as always. And then what questions do you guys have?